Today I will be presenting a case of heart failure. So the patient is a 74-year-old male, diabetic, hypertensive, presented with a history of dyspnea and exertion, class 3. He has had multiple admissions of heart failure admission. 6 months back was his first admission. His EF was 30% with global LV hypokinesia with severe MR and dilated annulus. The patient was started on GDMT. He underwent coronary angiography, which showed only insignificant CAD, managed medically. The patient's hemoglobin was 10.3 milligram per deciliter. The patient underwent correction of anemia, and patient reached the maximum tolerated dose of GDMT. Despite correction of anemia and maximum tolerated dose of GDMT, the patient continued to have repeated hospital admissions, amounting to about 4 episodes in the last 6 months. ECO, EF was 30% with global LV hypokinesia with severe MR. His lab parameters showed a hemoglobin of 12.3, a total count of 9,400, platelet of 2.64, creatinine of 1, potassium of 4.1, and NT-proBNP, which was staggeringly elevated to 7,240. The ECG was did not have a broad QRS complex, is what is the most important thing I would want you all to notice in the ECG, that it was not an LBBA pattern and it was a fairly narrow QRS complex. The the echo showed severe mitral regurgitation with LV dysfunction, EF of 30%, and only mild AR. The mitral valve area was normal, about 4.98. Patient had moderate PH and moderate TR with a PSP by TR jet of 46 mm of Hg. These are the transesophageal views, which again show that the patient had a significant MR and had an adequate mitral valve area of 5.44 centimeter square. The patient, we calculated the Euro score 2 for this patient just to probably define his surgical risk, which came to about a 9.95%, that is about 10% mortality if the patient would have been subjected to a mitral valve corrective surgery. So what should be the next course of action?
So just wait.
Yes, sir.
So recurrent heart failure hospital, just go back.
Yes, sir.
So, recurrent heart failure hospitalization. So GDMT, the most important thing in GDMT is the correction of anemia. That is the one of the most important thing. Second thing is that if the heart failure hospitalization is recurrent and patient is having wide QRS or PR prolongation, then one can think about resynchronization therapy. Sir is already here, so he is the world authority on that. But if the patient is having very narrow QRS with correction of anemia on GDMT but getting recurrent hospitalization, and it is all because of mechanical lesion of mitral regurgitation, then we have to think about doing something to that regurgitation lesion, and that thing we are just discussing here.
Is it the current correction of anemia or correction of ferritin?
It is a base.
Hemoglobin level does not sometimes may not correlate with what is the level of ferritin.
So here, as far as my center is concerned, we are just sticking to the hemoglobin levels. We are correcting most of the time with the ferritin only, so giving iron supplements along with the B complex, and if the patient is not responding to that, then if the patient is having high low GFR, then we sometimes give supplemental erythropoietin also.
What is the hemogram on this patient? Sedimentation rate and CRP, anything was done? Why is the hemoglobin persistently low?
Sir,
No source of blood loss.
No source of blood loss, sir. The only hemoglobin was low at his initial presentation, sir.
CRP and ESR, sedimentation rate,
Sir,
and CRP.
ESR was around 34, sir, and CRP was 6 to 8. It was not very
6 to
severely
8 is elevated.
It is not very severely elevated, sir.
No, the reason is when you have two valves, there's a mild AR and mitral regurgitation plus mild AR, you should think of an inflammation. In the absence of this, you need to look for inflammatory parameters in this. Valvulopathy is a known manifestation of either sarcoid or tuberculosis, unexplained valvular. They never present as obstruction. They always present as unexplained regurgitation.
This patient is ischemic heart disease. I think he had underwent a revascularization procedure, and it was a ischemic heart disease with a mitral regurgitation.
This patient was normal angiogram, sir.
Normal.
Angiogram.
Then discuss the echo parameters.
So the patient's selection for anatomical suitability of mitral valve transcatheter edge-to-edge repair. A patient would be said to be a non-complex ideal case for MTR if the patient has a central pathology with no significant calcification in the grasping zone and a mitral valve area of more than 4 centimeters square, a posterior leaflet of more than 10 millimeter with a tenting height of less than 10, flail gap of less than 10 and flail width of less than 15 mm. This parameters start not being followed by the patient, then it starts becoming more complex, and finally at a certain point it is hard or impossible to perform an MTR in patients who have concentric MAC with stenosis, mitral valve area of less than 3, already a mitral stenosis with a gradient of more than 5, a posterior leaflet of less than 5, calcification in the grasping zone, deep regurgitant cleft, leaflet perforation, multiple white jets and rheumatic mitral stenosis. So one very important thing that we have to understand prior to going for a MTR is what kind of mitral regurgitation does the patient have. So there are two major studies which were done, the MITRA-FR and the COAP study. So two different types of phenotypes were defined in both of these studies. There was a MITRA-FR phenotype which showed a proportionate severe MR which was proportional to the LV dilatation, whereas in COAP phenotype there was no severe LV dilatation, however the MR was very severe. The patient who had a COAP kind of phenotype responded better to TEER compared to those with a proportionate severe MR, whereas patient who had a MITRA-FR like phenotype, that is proportionate MR, responded better to GDMT compared to those with disproportionate MR. The atrial MR, there are not sufficient studies to support MTR in atrial MR. So these are two echoes which are showing the MITRA-FR like phenotype and the COAP like phenotype. Our patient had this phenotype, that is the COAP phenotype. It can be observed that it looks like more of a disproportionate MR. If you see the LV doesn't seem very dilated, but the MR is quite severe. Whereas in the MITRA-FR, the LV is dilated and the MR is proportionately severe to it. And in such patients, the MITRA-FR phenotype, the patients tend to respond poorly. There was almost a mortality rate of 28% in MITRA-FR like phenotype after 1 year of follow-up. So our patient had a COAP-like phenotype and hence MTR was planned. So what are the steps of MTR? So first there is immediate pre-procedure.
So there are 1 or 2 points here.
Yes,
We are dealing with a functional mitral leak, okay?
Yes, sir.
And here the volume status is very important. If the patient is is dehydrated, you will see the MR being mild or mild plus. If the patient is not adequately given diuretics and he is a little overhydrated, there will be a severe MR.
Yes.
So I suppose you have done the echo when the patient was more or less euvolumic and you have given a challenge.
After treatment, yes, sir.
Okay. And you didn't discuss about the third trial, which was supposed to be the tiebreaker. Okay. So there was a MITRA-FR which was negative, COAP was positive. Reshape heart failure HF2 trial was done to consider to just solve this missing link of the puzzle. They included both group of patients, the MITRA-FR plus COAP, and still the answer was not very clear. If we treat these patients, from Reshape heart failure 2 trial, 50% of the patients anyway they are dying if you do mitra clip or my clip in next 2 years. So especially these functional MR patients should be treated are evaluated very thoroughly before you take a call. Yeah.
The MRs are always dynamic. They depends upon the volume status. So when the patient was hospitalized in spite of proper therapy, and after hospitalization when IVC was collapsing, at that time we had done this echo and it had shown there is a significant mitral regurgitation and it is fulfilling all the criteria, ideal criteria to go for a clip, and just to avoid afterload mismatch we had just done the procedure with only single clip. Single clip.
The 7 steps of MTR are immediate pre-procedure evaluation, which is probably the most important step. A pre-procedure TE should be done so as to avoid a miscalculation of mitral valve area, miscalculation of mitral valve gradient, because this can give rise to catastrophic complications post-procedure. A special mention should be taken about transseptal puncture, because this is one of the most common site where they can undergo a complication. Apart from this, then there is advancement of the clip delivery system into LA. We have to adjust the clip position and the orientation, and this position and orientation adjustment can only be done in the LA once the clip has entered the left ventricle. The adjustments are difficult to make and should not idly be made. Once the advancement of the clip is done in the LV and the leaflet is captured, we have to, after capturing the leaflet, we have to look for residual MR, and we have to look for whether the patient has developed mitral valve area reduction and a significant gradient, and after this we can release the clip and we have to close closing views. So these are the steps which are seen. Here we can see that MDC is actually the guiding catheter into the LA. MDS is the MyClip delivery system into the LA. So we can see that we are entering the MDS into the LA. So here we can see that we are trying to grasp the both the anterior and posterior mitral leaflets. So here in the 3D we have tried to show that whenever we are entering the LV from the LA, we should never enter parallel to the valve, because it will be difficult to grasp the device and it will be difficult to maneuver the clip into the LV. Hence, we have you can see here that we have oriented the MyClip perpendicular to the.
Excuse me, Dr. Ponde sir.
We have oriented the MyClip perpendicular to the valve opening so as to easily be able to navigate the clip. Here again, we are trying to capture the device. Here we can see both the clip very beautifully. The clip is visible, but however it is not grasping adequately. Here we can see that the grasp is not very proper. Hence we have repositioned the MitraClip device so as to find the maximum point of regurgitation, so as to be able to reduce the regurgitation. So in the last slide we can see that the device has properly grasped both the leaflets, and in the next view we can see that the once the leaflet has been grasped, the mitral regurgitation has reduced significantly. In the lower panel are the fluoroscopic views showing the same. The entire procedure was done under TE guidance. So again, fluoroscopic view showing how the clip was manipulated and how it was grasped. So what are the possible complications after an MTR? So there are device-related complication, procedure-related complication. So structural failure, that is a single leaflet device attachment, that is only single leaflet gets attached to the device and the other leaflet is just left. The device can embolize, a leaflet injury can occur. Despite adequate proper placement of the device, the patient can still be left with residual LMR of more than 2+. The patient can develop mitral stenosis with a transmitral gradient of more than 5 mm Hg mean pressure. Other procedure related complications are access site vascular complications, cardiac structural damage, bleeding and thromboembolic events. One important problem that can occur is hemodynamically relevant interatrial septal defect. Since the MDS is almost 22 to 24 French, which will amount to around 7 to 8 mm. So this can be quite a large defect, but most of the time these are self-sealing, and most often they don't tend to develop a significant shunt, and this has not been defined. There is another complication that very commonly occurs, which is again more common with the mitra FR like phenotype compared to the coap like phenotype. So it is afterload mismatch after tear, and of course after even mitral valve repair or replacement surgery also this can occur. So this majorly occurs because once we correct the severe mitral regurgitation, this will acutely eliminate the low resistant regurgitant pathway, which will expose the already dysfunctional left ventricle to a sudden increase in effective afterload. So this is again seen after, as I have already told, tear and surgical mitra clip, particularly in patients with reduced DF and LV dilatation. So what are the clinical impacts of this condition? So this can be associated with acute LV failure, refractory hypotension, low cardiac output syndrome. Observational studies show that this condition is associated with increase in hospital mortality, but however, once the patient recovers from this condition, there is no adverse outcome on long-term survival. So this explains early hemodynamic instability despite technically successful MR correction.
So this is one of the most important things. So we have to judge at the time of the procedure. If the ejection fraction is less than 20%, then you have to always keep some significant residual mitral regurgitation. If you try to correct it 100%, putting additional clips or reducing the mitral valve area and reducing the mitral regurgitation, the patient will end up in very severe hypotension and afterload mismatch. In the ejection fraction range of 25 to 30%, the chances are very less, but 20 to 25% is a gray zone, but less than 20, it is 110%. You have to be very, very, very careful about this particular condition.
So LV arterial coupling studies show that sudden rise in effective arterial elastance after MR correction overwhelms the contractile reserve. So in surgical literature, consistently reported as a cause of post-repair cardiogenic shock, often misattributed to ischemia or hypovolemia. So how do you manage this condition? By avoiding pure vasopressors like noradrenaline, because this can increase afterload and worsen LV systolic performance. The first line pharmacological therapy for this condition would be inodilatation rather than pure vasopressor agents like melatonin and dobutamine, which not only improve contractility but reduce afterload and improve ventricular arterial coupling. So mechanical support whenever it is needed, whenever indicated, should be given to the patient. IABP is known to benefit in this condition by reducing the afterload via systolic balloon deflatation, increasing coronary perfusion via diastolic inflation, and it is particularly helpful with preserved RV function. However, our patients did not have any such complication and was discharged 2 days post procedure in a vitally stable condition. So at 3 months follow-up, the patient is currently in class 1 or 2 symptoms with a hemoglobin of 12.7, creat of 0.9. NT-proBNP, as you can observe, has decreased significantly to only about 426 picogram per ml, and the patient is now able to at least exercise. The 6-minute walk test being 312 meters, not ideal, however improved from the time the patient had first presented to us. It is important to note that the patient is still very compliant to GDMT. It is not that we did mitra clip and patient left medication and he was all right. He is still very compliant to medication, and that is how he has shown benefit. This is the echo of the patient, which shows that the MR has significantly reduced, and so has the pH. With the PSP by TRZ, which was initially 48, has now reduced to only 26. In conclusion, MTR has become a cornerstone in MV therapy. There is an established role in MTR in currently the most important transcatheter treatment strategy for mitral valve. Technical device enhancements and accumulating procedural experience have validated its efficacy across broad spectrum of NV anatomies. Where do guidelines stand on regarding MTR? That is class 1 indication for patients with ventricular secondary MR with ideal anatomy, and 2A for primary mitral MR, only when the patient is high surgical risk and the patient has suitable anatomy. Clinical relevance and registry outcomes reinforce the effectiveness of MTR in addressing complex MV and TR pathologies. Thank you.